Thank you very much, Ahmed. Ahmed is the one behind the scene. His support and his activity is more tremendous for this module. I see Professor Atul already joined. How are you, Professor?
I'm very good, thank you. And I'm looking forward to joining you, my dear.
Thank you. Thank you,
Mehdi is
Professor.
also here,
Hello.
and I can see many good friends of mine. Thank you very much, Ahmed.
Thank you, Professor. We are pleased and honored to have you with us, and we are thankful for your participation with us, Professor. How is Dr. Hamid Amran? He is still with you?
No, he's not with me. He's with you. What is the news? Tell me. I don't have any news about him.
I didn't meet him since a long time, so maybe I'll call him today and talk about the new news.
I hope
He
he's
learned a
all
lot of
right.
good stuff with you.
I hope he's all right, but I have no news about him, Ahmed.
I will call him today and see what he does, because I don't see him since a long time.
Please find out about him and
Okay.
let me know. I want to, he's such a fantastic young neurosurgeon. I hope nothing has happened to
Yes,
him.
he's very active and very enthusiastic also.
Yeah.
I think he will be joining us today. I think that. Let me call him and see if he can join. So, Professor, it's already time here. Professor Mahdi, if you can
Yes.
start.
We can start.
Yes, Professor, please.
Okay, thank you very much. I am very happy to chair this session of a second webinar of spine, and I am happy because the speaker is a great master, Professor Atul Goel. He is the king of spine. It is difficult to introduce him because he has a long CV, and I am very happy to introduce Professor Atul Goel. He will talk about approach in cervical spine degenerative cervical spine posterior approach, and we have as a moderator Dr. Kevin Tsang from UK. I can give the speech to Dr. Kevin Tsang to moderate this session. Thank you.
Thank you very much. Thank you. No, we're very much looking forward to Professor Go's talk on cervical spines. I think probably the best thing is we don't waste any time, let Professor get on and give us all his pearls.
Just a minute. Just let me get set a little bit.
No problems.
Can you hear me?
Yes.
Yes.
Very well.
Okay. Let me see the. I'm not sure if I can. Okay. Can you see my slide?
Yes, we can. Thank you very much.
Okay, dear Kevin, my dear Mehdi, dear Ahmad, I'm going to repeat what I have been talking about for a long time. Mehdi has heard this about 20 times, but because it is new, because it is fresh, because it is different, because it is a revolution in spine, I have no hesitation to repeat this lecture any number of times as I am required to, because more and more and more I get involved with this concept, more and more I get convinced with this concept. And there is no hesitation for me to say, no hesitation at all, that whatever I am going to say is different and whatever I am going to say is the future of spine surgery. There will be controversy. There are a lot of controversy. There will be a lot of disagreements and things like that. And Whatever, that is for others to think about and others to get the solution. But what I think about this subject, I am going to present. It is different. So, as I have said, I am going to repeat my lecture. So those who have heard still may enjoy this. Let us see. If you ask any spine surgeon on the planet, any spine surgeon, the issue will be there is a compression, and this compression is on imaging, on MRI or on CT scan. Imaging, you see compression of the nerve or nerve root or spinal cord. And for the whole world of spine, there is one treatment, and that treatment is decompression. So this is an accepted form of protocol for not only for degenerative spine, for the whole spine. So now what I'm going to talk is a little bit, I'll talk on craniovertebral because it is absolutely related. And then I will talk on degenerative spine. So this was my editorial, and this, of course, this editorial was different. Like in spine surgery, compression is not an issue and decompression is not the treatment. So this title of editorial can be quite difficult for people to realize, to understand. So that is the issue. Now, if you see, this is a horse and this is a four-legged animal. All the muscles of the four-legged animals are on the shoulders and on the hip. There is not much stress on the spine. In this bird, there is all the muscles are focused on the shoulders of the bird. There is not much focus on the spine. But the human body is different, and all our muscles are focused on the spine, not on the shoulder and not on the hip. Of course, this man is quite a strong shoulders he has, but basically the muscles are focused at the hip because we are standing on two legs like no other animal. There is one resemblance with this animal who stands on two legs, but he's still evolving and he's still not straight. His center of gravity lies in this direction, not in this direction. But still this animal is trying to become straight. But he has not managed because his muscles of the back are not as strong. When the fetus is born, you see the muscles are not strong and the head is falling, and there is like a hump, like a four-legged animal. This head falling becomes straight after about 3 or 4 months when the muscles of the nape become strong, and when the muscles of the spine become strong, the person is able to stand straight. So this is the evolution of the human spine. And if you see this animal, this four-legged animal, the center of gravity is on a different level. However, here, the center of gravity is along the spine, and the person is able to stand on two legs because of the muscles which are focused on the back of the spine. All the muscles are focused on the back of spine. There is hardly any muscle in the front of the spine. So this is another miracle of the disc. And of course, I will not be able to talk too much because of the various issues, but those who will be interested should read my fascinating small little editorial on disc and how the disc is divine. And disc is the mother of the spine. Disc comes first, vertebral body comes second and last. Disc is it gives information to form the bone. So bones are formed. How the disc dictates. So disc is like air in your car tire. Your car cannot run for more than 5 meters if there is no air in your car tire. But for your car to run, you need petrol. You need your motor. And that petrol and that motor is your muscles. So disc is the is a strong point. It is the center of your, like air in your car tire. It gives you movement, it gives you strength, it gives you shape. So this article, I wish you can read. So there are many beautiful things that have been mentioned in this article. So if you see the human spine, all the muscles are focused on the back of the spine. They are the center of activity, or the fulcrum of these muscles are on the facets. Even if there is a muscle attached to the spinous process or on the transverse process, the activity of these muscles is focused on the facets. So this is the motor of your car, of human body, motor. And the muscles are your petrol or diesel. And this disc is the air in your car tire.
I wonder if Professor's internet
Is
might be
there any
slightly
problem in connection?
interrupted. Yeah, I think his
Yes.
connection might have been
That
interrupted.
yes, it's frozen. So
Yeah,
let's wait. We
it'll
can
give him a couple
join.
of minutes.
Okay, let's wait.
Ah, here we go. Professor, you're back. Oh, you need to unmute.
Could you unmute yourself, sir, please? Thank you.
I'm not sure if Mehdi, you're listening to this, Mehdi, my dear.
Yeah, now yes.
Okay. So all the muscles are focused on the facets, and all the muscles are designed to keep the human body straight in standing position, sitting position, dancing position. And when these muscles become weak, there is instability at the point of facets. And this instability cannot be or may not be identified on imaging. Like MRI will not show you this instability. CT scan may not show you this. There is a subtle listhesis at the facet. The nape of neck takes care of the head and shoulders. So the atlantoaxial joint has very strong muscles of the nape of neck. So if you see this, this is the facet fulcrum, and these are the muscles. The nape of the neck has very strong muscles because it gives rotatory movement to the head and to the neck. So these muscles are the strong. But all these muscles, whether they are nape muscles or back muscles, they are all focused on the spine, on the facets. And when they become weak, there is a facetal instability. You have to just believe me. This understanding of the facets and of the muscles has the potential to completely revolutionize spine surgery. Okay, let us see. When these muscles become weak, there is a listhesis at the facet in the subaxial spine, and they leads to vertical facetal instability. And this is the point of genesis of spinal spondylotic disease. If you see, the whole world talks about degeneration, they say that the disc has finished, or the water has finished, or disc has degenerated. I must tell you, disc is divine, disc is mother, disc can never go wrong. And I will talk about it. So there is a telescoping of the spine. If you see your grandfather, he is shorter than you. Your grandmother is shorter than you. Why she is shorter? Because there is a listhesis at each facet and reduction of the joint space, which leads to reduction in the height, and it can lead to unstable spine. So in craniovertebral junction, we had talked about listhesis of the facets. in 1999, so 27 years ago, we had said that this listhesis of the facet of C1 is like listhesis of L5 over S1, and this is the cause of basilar invagination. Nobody had talked about it before. And this kind of issue, this basilar invagination, the whole world was doing transoral decompression. For the first time in the literature, we said listhesis is the issue, instability is the problem, and stabilization is the treatment. This is 1999. More recently, about 15 years ago, we introduced another beautiful concept in craniovertebral junction. I have no hesitation to say, absolutely no hesitation to say that this is a complete revolution in the craniovertebral junction understanding, the concept of central atlantoaxial instability. It is this instability is the cause of basilar invagination, Chiari, syringomyelia, and several other issues, which I am going to briefly talk about. So this is the scenario 1. When C1 over C2 listhesis is the problem, atlantodental interval is the issue, there is compression of the cord. So this was treated by transoral surgery in the whole world. In the year 2000, we said 26 years ago that this is unstable, this needs stabilization. Now this chapter is closed, the whole world, almost the entire world follows this concept. Now you see type 2. This is a big basilar invagination. Still, the whole world will like to do foramen magnum decompression here. There is no atlantodental interval disturbance. There is no compression. But look at the facets. There is retrolisthesis of the facet. In my view, this is clear. Not my view. This is absolutely published and done with view that this is unstable. This does not need decompression. This needs C1, C2 fixation. Absolutely no confusion in this. The third thing is when the facets are in alignment, presence of basilar invagination, presence of platybasia, presence of assimilation of atlas, syringomyelia, Chiari malformation, these are all secondary manifestations of chronic atlantoaxial instability. They indicate unstable spine. You stabilize and you create a magic, not only in clinical perspective, but radiological perspective. So I am not going to talk, as I said, too much on craniovertebral junction, but this slide, if you see, chronic atlantoaxial instability, chronic, not acute. There are several things that you are seeing in these short circles, like Chiari, syringomyelia, C2-3 fusion, Klippel file, platybasia, external syringo, basilar invagination, short neck, bifid, orthodont, and several more. They are all secondary to instability. They are all naturally protective. All are naturally protective. And all are potentially reversible following atlantoaxial stabilization. So you can see there's such a huge difference in the concept. And if you see the literature today, when we talk of Chiari, we talk of decompression. When we talk of bifid, we talk of decompression. When we talk of basilar, we talk of decompression. So these are all treated currently by decompression. And I am saying decompression is a negative treatment. Instability is the issue. Stabilization is the treatment. Chiari may be associated with syrinx or may be associated with basilar, or maybe basilar is a discrete issue. Syringomyelia is a discrete issue, may be associated with C2-3 fusion, Klippel file. So all these things which you are seeing, and many more, which you can read in my articles, when they are present discretely or in cohort, they all indicate unstable spine, atlantoaxial joint, and stabilization. So acute instability is different. Chronic instability, there are several natural reparative mechanisms. So basilar invagination, syringomyelia, Chiari formation are all due to atlantoaxial instability, and many of you have read this article in Journal of Neurosurgery where I said that Chiari malformation is due to atlantoaxial instability. Still, there is a lot of, people like to argue, like to have confusion, they disagreement, ridicule, all those things. So that is their own business. What I am going to tell you here is what is my business and what is the real future of Chiari is that atlantoaxial instability, chronic atlantoaxial instability is the cause and atlantoaxial fixation is the treatment. So this is basilar invagination. There is no question of, you see, the whole world will say compression, compression, and decompression. But look at the facets. This is clearly unstable. You do fixation and you see the magic. The tonsil will go up. If there is syringe, it will reduce. And there will be several other issues. So there is no atlantodental interval disturbance, little bit facetal malalignment. And you see Chiari and syrinx, you do C1, C2 fixation. So now I have, you see, one can say, no, I don't agree. No, it is not correct. No, it is only here and I don't bother about what is here and what is there. This is proven on the basis of now more than 650 patients that we have operated. So there is basilar invagination, no problem here, tonsillar herniation. This concept of tight posterior fossa was introduced by us in 1998, saying that when there is Chiari, there is a tight posterior fossa. I am negating that my own concept that there is no question of tight posterior fossa. And we had recommended that only bone removal should be done. But now I am saying no bone removal should be done. Bone should be added. You see, the bone should be added. And for fusion, C1, C2 fixation is the treatment. Syringomyelia, syrinx can reduce in the immediate postoperative, and of course, delayed, there can be 100% reduction in syrinx. As I have mentioned, whether syrinx reduces or not reduces, that is not the issue. The patient will improve dramatically in the postoperative period, not after 1 month or 2 months, in the evening of operation. So there is basilar invagination, some facetal malalignment, C1, C2 fixation, syrinx reducing. In the immediate postoperative period, it can reduce. So this was my article, which was published about 5 years ago, where we talked about 388 cases. Now we have more than 650 cases. And there is no argument for the young people. I'm saying clearly, this is the future. If you agree, okay. If you don't agree, you can read this article carefully, bit by bit by bit. And even if you don't agree, you please come and join me in my department and I will show you many cases. So, and from Yemen, as I have mentioned, this presentation is basically, I see from Yemen doctors, and many people from Yemen have joined me. So Chiari is secondary. It is protective. It is natural protection. It is not a malformation. It is a formation. Like syringomyelia is secondary to chronic atlantoaxial instability. This article of mine was published in 1996, 30 years ago, that Chiari syringomyelia is a natural protection. When syrinx is present with Chiari or without Chiari, with basilar or without basilar, with Klippel file or without Klippel file, or only syrinx, the only treatment of this kind of syrinx is, we call it idiopathic syrinx, and this treatment is drainage or shunt. This is a completely negative form of treatment. This is due to atlantoaxial instability. You stabilize and you see the magic. Musculoskeletal abnormalities like short neck, torticollis, you do fixation. Like, when there is a disc herniation, the person has scoliosis. Why there is scoliosis? It is a natural protection. So when there is torticollis and short neck, both are natural protection. You do C1, C2, the neck becomes long, the neck becomes straight, and the smile becomes big and strong. You see this neck and you see this neck. Not only the neck, the hands, if there is problem with the fingers and legs and spasticity, everything will improve. So cervical fusions are secondary, they are protective, and they are, you see this fusion, there is no compression. Now what you want to do, if there is this person is not able to even breathe properly, don't start doing decompressions because there is fusion and all those things. There is an unstable spine. you do fixation, and you see a magic. I don't want to talk on several other issues because this is not topic based on craniovertebral junction, but even kyphoscoliosis, which is remote from craniovertebral junction. There is in craniovertebral junction instability, lungs instability. There can be short neck, short head, short spine. There can be torticollis. There can be kyphoscoliosis. This kind of kyphoscoliosis, if you go and ask any spine surgeon, he will do at least 30 screws on one side, 30 screws on the other side, 1 kilometer of rod. This patient does not need any manipulation of the spine. He needs C1, C2 fixation, and the spine will become straight. You see this spine? And you see this spine? Now I've got several patients. So in short, whenever you see a patient with kyphoscoliosis, don't ignore the craniovertebral junction. So I have no hesitation to say that I demolished transoral surgery from the field of spine surgery. And I have no hesitation to say that foramen magnum decompression is destined to be completely become historical. So this is, now I want to go on spine. See, anterior spine surgery was my forte. I used to be very fantastic demonstration here, demo book chapter. This is Sweeten's Midek book chapter, which I wrote several years ago on anterior approaches. I was asked to write because I was known for anterior surgery. And this kind of anterior decompression, anterior surgery, and anterior, I was doing regularly in my department. I described oblique corpectomy for the first time in the literature. And I also described these tricortical screws, which you see these screws from here, 1 cortex, 2 cortex, 3 cortex, 1 cortex, 2 cortex, 3 cortex. So this is tricortical screw and plate, and tricortical screw here, unicortical screw. This is tricortical screw. This is standalone tricortical screws. This is single screw on in a tricortical fashion. This I described 30 years ago. Tricortical screw. Now I want to talk about my current concept. This is history. Degenerative arthritis of craniovertebral junction. There is no literature on degenerative arthritis of craniovertebral junction. In 2010, for the first time in the literature, we said that craniovertebral instability, you see this word instability, due to degenerative osteoarthritis of atlantoaxial joint in 2010. So for the first time in the literature, we introduced the word instability for degenerative spine. Now I want you to see carefully this slide. There is reduction in the joint space, buckling of this ligament, osteophyte formation. These are due to vertical instability. There is compression, looks like compression, but this is a natural secondary phenomena. Reduction in the disc space or body space is an adaptive response. This is a secondary protective phenomena. Osteophyte formation in the apical ligament behind the odontoid, front of odontoid process. Don't start looking at the compression and start doing decompression. This is clearly unstable. You stabilize. There is no need for decompression. Retroodontoid pseudotumor, the whole world was doing decompression. Whole world. Transoral decompression. Then some people introduced lateral decompressions, and far lateral and extreme lateral, all these kind of decompression. So this article of mine was the first in the literature where we said that this is like an osteophyte of craniovertebral junction. This is secondary to an unstable spine, and this needs stabilization. And this was the article which was published 22 years ago in a Japanese journal. And now many people in the world follow this concept. And of course, difficult for several people not to do decompression for this, but it is not necessary. Retroodontoid cyst. You see, this is unstable. This is in this situation, in this unstable spine. If you start doing, this is secondary, this is protective, this is reversible. You do fixation. There is retroodontoid small cyst. There is a hole in the bone. There is a dynamic reversal here. There is no need to come and start doing transoral decompression or posterior decompression. This needs fixation. So this is my article, which I wish you read. About 5 years ago, we published this article on retroodontoid pseudotumor panus cyst and talked about what to do. This panus, retroodontoid panus, if many people are not, many people are young in this audience, but those who are a little bit senior will know that this panus, the whole world was doing transoral decompression to remove this panus. And then some people started doing occipitocervical fixation. But what we said that this panus is due to vertical instability, you stabilize, and there can be immediate postoperative regression of the panus. So we introduced these intra-articular spacers for the first time in the literature in the year 2000, 26 years ago. And these were the spacers, and this is the joint jamming technique that we introduced, and we talked, this is in Journal of Neurosurgery. So this spine, you see this oblique, this is the facet, and because of this obliquity, there is a vertical instability. In the atlantoaxial region, the joints are flat, and there is a central or axial instability. In the subaxial spine, there is a vertical instability. So this is atlantoaxial, there is a transverse or axial instability. In the subaxial spine, there is a vertical instability, and this instability may not be, this is unstable, but it is not recognized on imaging. You do dynamic flexion extension, it will not be recognized. Now carefully look at this slide. Reduction of the interbody space, bulging of this disc, osteophyte formation is not a primary phenomenon. They are secondary to vertical facetal instability. They are not a problem. They are not harmful. They are secondary, they are protective, and they are reversible. They indicate unstable spine, and you have to stabilize this spine. So about 20 years ago, we introduced this concept of facetal distraction, introduced these spacers in the facetal articulation, distracted the facet. You see this pre-op and post-op, this immediate post-op, the bulging disc has gone, the disc space has become new, the ligamentum flavum has become straight, and we published several articles on this subject during about 20 years ago. You see this ligamentum flavum, and this is immediate post-op. By putting these spacers, the flavum has gone, the disc, and if you see all the disc space, there is white or fluid in the disc, which was not there before operation. So this was the technique that we published in Journal of Neurosurgery. It was on the cover page of Journal of Neurosurgery in 2011. And you see the title, Facetal Distraction as Treatment of Single or Multi-Level Cervical Spondylotic Radiculopathy and Myelopathy. Radiculopathy. Same thing we talked about lumbar canal stenosis. You see these bulges and this compression and this stenosis, everyone decompression. This is due to vertical instability, due to multi-segmental muscle weakness. There is a facetal instability, and you have to we introduced these kind of spacers for fixation, and this was the article which was published in 2013 in Journal of Neurosurgery, and these were the pictures. And we did several cases during that time for fresh cases of lumbar canal stenosis, for failed lumbar canal stenosis, and things like that. So lumbar facet distraction and fixation for patients with lumbar spinal stenosis and outcome. So these are my spacers which we patented long time ago. So essentially, decompression has been the treatment for the whole world of spine for several decades. So in 2013, we introduced another concept where we say you don't even need to do indirect decompression by putting facetal spacers. Only fixation, only fixation. This was my concept for cervical spondylosis in 2013. Then in 2020, 6 years ago, we just read the title of this article, Muscle Weakness Related Spinal Instability. is the cause of spinal degeneration, and spinal stabilization is the treatment. Can you read this title? This was in World Neurosurgery. I have not talked anything about decompression. So you see this multi-segmental spinal compression. The whole world will do either multi-level corpectomy or discectomy. I was also doing. As I told you, I was good in it, and I was doing several cases. Or some people will like to do multi-segmental laminectomy. For multi-segmental degeneration, still the gold standard is laminectomy. Now some people have started doing fixation also recently, after our papers have come about instability. Recently, some people do decompression and fixation. Otherwise, the concept was multi-segmental laminectomy can introduce iatrogenic instability, and that is why you need stabilization. So this concept has now changed. Now you see here, I have not done any kind of decompression, only fixation, and after 18 months of surgery, you see the whole, these osteophytes have finished, the ligamentum flavum, the spinal cord is dancing to glory. This is multi-segmental issue, ligamentum flavum, this and that. You can imagine the treatment, 4-level corpectomy, the whole world says about 35% complication rate, and not only small complication, big complication rate of 35%. Laminoplasty is a nonsense, useless procedure, and all those things. This is my concept. My language, you please ignore it, because my concepts are now fixed and ingrained in my mind. And I like to, I take back my nonsense word, but this is, you see, there is no decompression, no laminectomy, no laminoplasty. And you see, after a few months of surgery, the whole osteophytes have finished, the ligamentum flavum. And if you see some white in the disc has come and everything. So essentially, and most importantly, the patient will recover in a form of a magic in the immediate postoperative. Immediate, I'm talking, mind this word. So we should look at degenerative myelopathy in a different perspective, not in the perspective of compression and not in the perspective of decompression. Instability is the cause of symptoms and stabilization is the treatment. And there are several articles of mine which you will like to read. The most important issue in degenerative spine is what are the indicators of spinal instability. That is one thing that we have to understand. Second thing is we have to understand which levels have to be stabilized, which level. For instance, here there is 2 levels of compression, but I have fixed 4 or 5 levels of fixation. So why for 2 level, 4 level or 5 level fixation? That is a very critical thing in spinal degeneration, and that you please read my article on this subject. And you see, after a few months of surgery, the whole thing has changed, and you have to just believe that this patient has got a new life. So multi-segmental compression, and you see the whole spine has changed. There is only fixation. There is no laminectomy. There is no decompression. And there are several 100 patients now with me, and I have no hesitation to say that this is the future. Only thing is, it is completely different from what is existing, and that is why for people to accept it is not such an easy job for me. I'm trying and I will continue to try. And this is my technique of fixation. I do Camille's technique of fixation. Sometimes I put 2 screws, and more often I put 1 screw at each level. Another beautiful thing that nobody in the world of spine has ever talked about is atlantoaxial instability and subaxial spinal instability are commonly associated with multisegmental spinal spondylotic disease. So like this here, multisegmental, there is no compression here, but look at the facet, it is unstable. This patient needs stabilization. This patient does not need decompression, and this patient needs atlantoaxial stabilization also. And you see this multisegmental, this thing, there is no compression here, but I have included the C23. C23 segment inclusion, it introduces an alternative technique of atlantoaxial instability. You have to read my article on this alternative technique where I don't include C1 in the fixation construct. When the patient has severe spondylosis, in those cases, severe patient comes on a wheelchair, patient comes on a trolley, you have to do only fixation, that is one. You don't have to do any kind of decompression, that is number two. And you have to include C1, C2 in the fixation construct more often than not. And in these patients nowadays, I do alternative C2-3 fixation. So this is the patient during COVID time she had come. You see huge osteophytes in a difficult, you see that everything has cleared up and my fusion is at these levels. And this is another patient. This is another patient. So I have got several beautiful radiological imaging. Another dangerous concept, dangerous, and you have to agree with me, dangerous concept of lumbar canal stenosis. And you read this article published in Neurosurgical Focus. The title is Analyzing the Role of Stabilization and Futility of Decompression. You see this very powerful word of decompression, futility. The whole world is doing this futile exercise of decompression in my view. So if you see this multisegmental compression and all, they are due to multisegmental instability, multisegmental muscle weakness. Stabilization is the treatment. There is no role for any kind of decompression. Identify which levels have to be fixed, and that is the most critical part. So this word stenosis, when you say stenosis, means you have to decompress. This is a completely wrong word, and this is a completely negative word. If you call stenosis, then this is wrong. So this is a misnomer. You should call it multisegmental spinal degeneration. And we have done it for failed decompression and several other situations like this. In young patients, the lumbar canal stenosis is different. In old patient, lumbar canal stenosis. So you have to read my article on this. So bottom line is it necessary to remove the osteophytes in degenerative myelopathy? Is it necessary to do decompression? Read this article. My answer is no, it is not necessary. So, and this is my article published in World Neurosurgery, where I am analyzing what was my outcome of osteophytes after only fixation and minimum 12 months of follow-up. So this is an osteophyte. There is no decompression. Osteophytes are finished. And there is fusion, basically unstable. Deformities of the spine, cervical kyphosis. You see this kyphosis? You go for any spine surgeon, he will say kyphectomy I will do, osteotomies I will do, decompression I will do. This is not a game of decompression. This is unstable. You identify the level of instability and stabilize. That is the treatment. Here you have to do C1, C2 fixation. Here there is subaxial fixation, when to do what and how to do. This is in my article in World Neurosurgery. I wish that you please read it. Now I will talk about another highly controversial subject, herniated disc. As I have told you, disc herniation, disc is a divine structure. Disc can never go wrong. Disc herniates as a protective natural mechanism. You see, this herniation, the whole world will do ACDF, which I was also doing. But now I'm saying this herniation is secondary to focal spinal instability. Imagine if there is a disc herniation, what will be your first treatment? You say, okay, wear a belt. Okay, you wear a collar for 3 months. And if it goes, why you say wear a collar? Because it is unstable. You know it is unstable. And with the collar, the person feels very stable, very pain relief. But little bit movement of the neck, little bit movement of the back, unstable spine, there is pain. So this is secondary to unstable spine. And this was my beautiful article in World Neurosurgery, where we said fascicle fixation arthrodesis is the treatment of cervical radiculopathy. Same thing in lumbar radiculopathy. You don't have to do any discectomy. So this is a dramatically different concept. And you have to think about, you have to try to understand my concept, and you have to accordingly change. So this kind of scoliosis, there is no need for decompression. And this is all my statements are very heavily published in the literature. Every statement which I am making is heavily published. So I'm not saying anything which is not published. So you don't just take it that this is some kind of a arbitrary kind of a talk. Another thing, OPLL. OPLL, most dangerous issue in spine surgery. So this was my article that OPLL is secondary to unstable spine and only stabilization is the treatment. Few years ago, I wrote my experience on 52 cases in world neurosurgery on only fixation without any decompression. Now my experience is nearing 200 cases. I have no hesitation to say, no confusion to say that this is the treatment. And please don't do any kind of decompression because it is dangerous, because it is difficult, and because it is harmful, and because it is not necessary. And I have to also tell you that I described for the first time for OPLL, oblique corpectomy as a treatment. I am saying myself that it is not necessary. Atlantoaxial instability is very frequently associated with OPLL, and you have to include this kind of fixation in the fixation construct. Nowadays, I do C2-3, I don't use direct C1 insertion screw. And we have got several patients where there may not be so much radiological change after 2 years or 3 years or 5 years, but clinically the person is cured. So essentially, atlantoaxial and subaxial spinal fixation can revolutionize the treatment of myelopathy related to OPLL. So these are some of my articles where I am saying that decompression as a treatment can be completely historical. I have no hesitation to say that this is the future. Difficult to understand, difficult to evaluate. Hirayama disease is another issue which I have talked about, where I have said that this is not due to any kind of dural ectasia or any kind of other kind of problem. This is due to multi-segmental spinal instability, and you have to do stabilization. So in short, my dear friends, compression is never the issue in spine surgery. It is never primary, it is secondary to unstable spine, it is protective, it is reversible, it indicates unstable spine, and decompression is never the treatment. And you are paying the price of standing on 2 legs. If you were standing on 4 legs, you may not be having any spinal problem. So thank you, my dear friends, and I hope you enjoyed this presentation. I hope you enjoyed these new concepts, which are different and which are absolutely 180 degrees on the other side. Thank you very much. Kevin, over to
Thank you,
you.
Professor Atul Goel, for this great talk, for your great talk and great experience. Thank you very much, as usual. Thank you. I give the talk to the
Thank you.
moderator.
Thank you, Mehdi. Thank you, my dear friend.
Thank you, Professor. That's a very, very interesting talk, an eye-opener for many of us, I think. So fantastic talk. Can I start off the Q&A session by asking a quick question from myself? So if you had a cervical myelopathy patient with the degenerative changes, but your scans do not show obvious radiological signs of instability, do you do any other forms of imaging to confirm instability, or do you say that this is going to be instability we will be fixing?
This is the question, Kevin. This is the question. And this question, you see, for Chiari malformation, for instance, for Chiari. In Chiari, as you know, the whole world is doing decompression. So we said that it is not, it is an unstable spine, we said. On the basis of lateral profile imaging and on the basis of facetal alignment, as I talked about briefly. Nowadays, we are doing head rotation CT scan. You do head rotation to the right side, head rotation to the left side, and head tilting on the right side, head tilting on the left side, and you do CT scan and analyze the alignment of the facets. So this is what we have now started doing for craniovertebral junction. And if the facetal malalignment is more than 50%, it is indicative. If it is more than 75%, it is very much indicated. But it is these parameters are also not validated by other spine surgeons in the world. But these are my parameters, and some there are some reports of validity of these parameters in the historical perspective. As regards subaxial spine, as regards cervical degeneration, as you are asking, as regards lumbar degeneration, as you might imagine, you do flexion extension imaging, there is no evidence of instability. But in my view, because of the lateral location of the facets, which are away from the neural structures, identification of instability on dynamic imaging is not always possible. But presence of osteophytes, presence of ligamentum flavum bulging, presence of disc space reduction, presence of ligamentous hypertrophy, ligamentous ossification, presence of various other factors are in of an unstable situation. And this can be validated during the operation. If you go and see, you see there was another article where I wrote presence of bone fusion and presence of bone formation is an evidence of unstable spine. Sometimes in degenerative spine, you will see evidence of bone formation, presence of fusions. So presence of fusion, presence of bone formation is an evidence of unstable spine. So these are evidences. You cannot have a kind of clear radiological dictate in the subaxial spine. Sometimes, like listhesis is there, which is manifest listhesis, sometimes facetal, that if you see carefully this, nobody has really talked about facets in degeneration. But if you carefully see the facets, there will be osteophytes around the facets, which have never been reported in the literature. How many you have ever heard of osteophytes around the facets? Nobody has said. But you can see facets around the osteophytes around the facets in the intervertebral ligamental hypertrophy. This is not hypertrophy. This is buckling of the ligament. If you see the literature, they talk of hypertrophic ligaments. You see the literature on lumbar canal stenosis, ligamentous hypertrophy. This is not hypertrophy. This is buckling of the ligament. And you can, if you have this concept in your mind, you go in the theater, you will find the buccal ligament, you will find an unstable spine, and that is the evidence. Kevin.
It's very interesting. And just a quick follow-up question. Do you think there's a role for upright imaging? Because I think quite a lot of centers are now doing upright MRI scans because, as you said, it's a vertical problem. Do you think
Yeah,
that changes anything?
that is also, a kind of investigation which I am also trying to analyze. But up till now, I don't think, Kevin, I have made one principle in my life. That principle is unless my thing is published, I don't talk about it. This is this is my principle which I have made in my life. So you please don't ask me this question. And I will, if it is published, then next time I will be able to talk about it. Okay?
Perfect. Perfect. Thank you. Thank you. Now, do any of our participants have any questions for Professor? You can put your hand up or you can type it into the Q&A and I can read it out.
Kevin, from where are you? Which hospital you are from?
I'm in London. I'm at St. Mary's and Charing Cross Hospitals in London at Imperial College. Yeah.
Very good, very good.
Yeah, so it's very interesting. We see obviously a lot of Chiari, a lot of these degenerative cases, and there's a constant discussion as to which patients should be fixed or not fixed. So this is, very
Kevin,
interesting.
this discussion regarding fixing or not fixing has started after 2013. There was no discussion of this kind before that. Even if you are discussing this, I can understand you are discussing, but ultimately you are decompressing. You will not be fixing because that discussion, it is not in my favor. It is always in the favor of history, but it is not in the favor of the future. Okay, Kevin?
Absolutely. Yes.
You are the
Thank
future
you.
of English neurosurgery. You please think about it and you please follow this future, okay?
Absolutely. Thank you. That's one question on the Q&A group. There's a question asking, during the fixation, do you remove the facet capsule or not?
articulation, yeah. You see, this is what I had described in 1988 for craniovertebral junction. For craniovertebral junction. Open the joint, remove the articular cartilage, stuff bone graft into the joint. You know what, Kevin, I described in 1988 when I was of your age, or maybe younger than you. Okay? So you must not, underestimate your own self. Age is not an issue. So I described this technique of C1, C2 fixation in 1988. Open the joint, remove the articular capsule, introduce bone graft, and then do the fixation for craniovertebral junction. Basically, your instrumentation will hold the bone for 2 months, and after 2 months, your bone will hold the instruments.
Yeah.
That bone fusion. Similarly, in subaxial spine, you have to depend on fusion. You cannot depend on just a screw.
Yeah.
The screw will be holding for 20 days, but it has to fuse in 20 days, and the fusion will hold the screw after 20 days. So for fusion to occur, you have to remove the articular cartilage. You have to denude the articular cartilage. In the subaxial spine, denuding may not be, in degenerative spine, particularly in cervical degeneration, lumbar degeneration, the articular capsule is already finished. You see, it is not as smooth as in craniovertebral junction. So you introduce a kind of osteophyte and turn it on this various direction to denude the cartilage. And if you have enough space, you can put some bone chips. But I don't put bone chips in all the facets because the articular cartilage is already gone. And this transarticular is such an easy technique. You'll be surprised, my dear Kevin. In my department, sometimes I do 5-level fixation in 10 minutes.
Oh, wow.
These transarticular screws are so easy and simple. Imagine 5-level fixation from anterior, corpectomy and all those things, 5-level fixation. You must read the literature on 4-level or more than 3-level fixation. There is a complication rate, published complication rate, major complication rate of more than 35%. And I am talking of such a simple technique. When I'm saying 10 minutes I can do and 5 minutes I can do, that is not the time factor. I'm trying to stress on the ease of the fixation.
Yeah.
On the solidity of fixation. And you must read my article on this technique. My screw failure rates are absolutely low. I don't exactly remember, so I will not tell you, but it is published.
Yeah. Very nice. Thank you very much. Do we have any questions from anyone else on the call? I can't see anyone else have typed any questions.
I will
Anyone
not go unless I have a question from Mehdi, my friend.
Yes.
Mehdi, you have no question?
No.
Okay.
Thank you.
It's a very clear lecture, I think.
Very clear, yes.
Information was very clear. Excellent. Well, I can't see any other questions on the call, so I'll pass back to you, Professor Mehdi. Oh, actually, one hand's just gone up from Dr. Parek. You can unmute yourself.
Atul,
Yes, Harshad, yes.
I'm patiently listening to you,
Okay.
as always. I don't know what refreshes every time that I've learned another something more to it every time when I hear. And this revolution of facetal instability and vertical instability you are bringing it in is really changing the whole world and following it to your technique. Wonderful. I must have heard you 100 times, but every time I feel it is I'm listening to you for first time. Oh, I didn't know this. You are enlightening everybody. So I thought I could not resist to compliment you for that.
Thank you so much, Harshad. And No, but I am convinced and I am sure this is the future. And I also know that it is difficult to convince people, but I am trying my best, Harshad. I am trying my best.
No, people are getting convinced.
Okay.
And
We also
I'm
have a
following you.
Okay.
we also have a hand up from a Dr. Perzad from Afghanistan. Let me just unmute
Yeah,
you.
Dr. Pirzad.
Hello. Hello. Salam
Yes.
alaikum.
Salam,
Namaste.
salam. Happy Eid to
Uh,
you. Are you
happy
celebrating?
Eid for our Muslim brothers. Happy Eid Mubarak. Thank you. Excellent lecture, Professor Atul Goel. We always learn from you, and it's appreciate from you, and thank you for our coordination of this webinars. Just I like to know, and we are facing in this case very much in Afghanistan for osteoporosis. What is your recommendation? Just sometimes we have very osteoporotic patients, and for fixation, what's your advice and recommendation? Thank you.
The osteoporosis. If I have to tell you which is the weakest part of the spine, Dr. Ahmed, weakest part of the spine is not anything else but the bones. Bones are the weakest part of the spine. They look strong, but they are weak. Disc is the strongest, muscle is the strongest, ligaments are strong, but bones are. You can strengthen your muscles by going to exercise, going for gymnasium. You can do, running. You can strengthen your muscles, but you cannot strengthen your bones. So for the bones, you have to, have a proper diet and things like that. The strongest part of the whole vertebra is not the vertebral body, is not the pedicle, is not the transverse process. It is the facets. If you hold the vertebra in your hand, the facets are the strongest. If you put a screw transarticular like Camille's technique, these are very strong screws. Even if there is osteoporosis, it is not manifested in the facets. So when you put facetal screw, if you have osteoporosis, maybe anterior cervical body screws may be difficult to introduce. Pedicle screws may sometimes be difficult to introduce. But the facetal screws are the strongest, facets are the strongest, and transfacetal screws have a very good purchase. So you should use facetal screws.
Fantastic. There is one more question on the chat. If we have performed the fixation, but the patient continues to be symptomatic or the syrinx hasn't resolved, does that mean the fixation wasn't correct? Should we be redoing the fixation, or is it now time to think about decompression?
So this is another, first thing is you have to agree with this concept that instability is the issue, that you have to agree and keep in your mind. If you see compression and you do always think about compression and don't think about instability, and that concept is not there, then that is problem number one. Problem number two is, as I mentioned, you have to identify which levels are unstable. You may think on radiology, here is an osteophyte at C4-5 and C5-6, let me do C5-6 and C4-5 fixation. But it may be C1, C2 is also unstable. It may be C2, 3, as I mentioned, I have done 5-level fixation for 2-level compression. So most important thing is that you have to identify correct levels of fixation, which is, if you ask me one question, that which is the most critical issue in degenerative spine, my answer to that question will be to identify which levels are unstable. That is the main critical issue. That is one. Second thing is, suppose you feel that, no, I want to do decompression and I believe in decompression. So if you have done fixation, suppose you have done transarticular fixation, and your patient has not improved, or you think that the patient needs decompression. So the whole midline is available for you. You can come and do laminectomy, or you can come from front and do decompression. Nobody stops if the patient has not improved, which has never happened in my career up till now. I have never reoperated a patient. But if it happens, your whole spine is open for you. You can come and do decompression from behind. Laminectomy you can do next day. Already fixation is done on the first day. You can do fixation, decompression, which will not be necessary. You have to believe in this concept.
Excellent. And then I think one last question on the chat. Would you still recommend a posterior fixation for OPLL, given it is already fused at the front?
So that is the very, it means whoever has asked me this question did not read or hear me when I was talking. I am saying OPLL, or ossification in front of the spinal cord. There are several people who say that this is a fixed anomaly, fixed. You see severe compression. Because it is fixed, the whole world does decompression. That is understandable. I am saying yes, the whole world. And I have also said that I was also doing decompression. I have also said that I introduced the technique of oblique corpectomy in 1990. I don't know the year, but I introduced this concept. So I was doing decompression. Now I am saying that this ossification of posterior longitudinal ligament is not due to any dietary factor, is not due to calcium factor, it is not due to regional factors, it is not due to Asian factors. It is a manifestation of an unstable spine. It is a visual manifestation or radiological manifestation of an unstable spine. So it is not fixed from front. If it is fixed from front, then it is fixed everywhere. Then why you need to do fixation? You don't need to do fixation if the bodies are fused. So it looks fused. So what looks is not the reality. Reality is it is unstable. Now, if you get a next patient of OPLL, you look at the facets on imaging. You will see the facets are clean and facets are unstable. You see your next patient. So that is the concept, which is why I am saying it is a different concept, which is why I am saying it is a revolution. Whether that revolution is acceptable or not acceptable, only time will tell. But if you can see the positive framework in which I am talking, nobody can talk in such positive unless he's absolutely convinced. Nobody will publish. There are 200 articles in the literature on this subject. Nobody will dare to publish if he is making fool of himself. He cannot make the world foolish. So these are published. These are not universally, but there are many fellows of mine all over the world who are doing this technique, all over the world. There are many people who listen to my lectures and do. Many people come here and see and then go. So this will eventually come, my dear Kevin. And now for the next case, you will also start thinking about it, okay?
Already thinking about it now, before the next case. I think that's a very strong message. Thank you so much, Professor. Thank you. I'm going to pass you back to Professor Mehdi.
Thank you very much. If there is another comment or question, now we can finish this session. And thank you very much, Professor Atul Goel. Thank you, Dr. Kevin, for your moderation. And thank you for all participants. And see you in next webinar. Thank you very much.
Thank you. Bye-bye.
Thank you very much.
Bye-bye.
Thank you so
Bye.
much. See you next Friday. Thank you.
Thank you. Thank you.
Thank you.
Thank you.